So, welcome everyone. Today's topic is what's SIBO and am I at risk? So, small intestinal bacterial overgrowth is a condition where there's an abnormal increase in the amount of bacteria in the small intestine. SIBO more frequently diagnosed in patients with gynecologic cancer. In this informal talk, Dr. Pashinsky will share the facts about what gynecologic cancer survivors need to know about SIBO to protect their gut. Dr. Yevgenia is a board-certified gastroenterologist who completed her medical education and training in internal medicine and pathology at the Mount Sinai Medical Center in New York. Within gastroenterology, she specializes in women's gastrointestinal health with a focus on pelvic floor dysfunction and nutrition. Her interests also include colon cancer prevention and general gastroenterology. So, thank you so much. You joined us a long time ago, and it's so nice to have you back. So, thank
Yes,
you.
my pleasure. Thank you guys for having me, and thanks everybody for signing in on this very hot date to listen. I'm gonna share my screen. I have, some slides. Actually, it's from a talk that we had done for it was a big sort of medical dietetic conference on things that include things other than SIBO. We're definitely going to talk about SIBO. We're going to focus on that, but if there's other topics that want to be touched in the process, I wanted to make sure that we have a little bit of that because SIBO is really not a very long topic, so I could, get you guys all completely expert at it within about 10 minutes, and then it's going to be less more time to just sit around and discuss the heat. So I'm gonna open up with a few other things, and then you guys will tell me what's not interesting and we could pass it. So okay, can everyone see my screen?
Yes.
Yeah, so we kind of called this talk initially was called IBS mimickers because, SIBO is actually one of those things that gets confused for IBS a lot and just kind of thrown into the mill. Hold on, let me just see here. I'm okay. Meeting's being recorded. I'm doing all of my little thingies so I could see what I'm saying. So I wanted to just sort of briefly touch on a couple of topics in addition to the SIBO. We're going to focus on it the most. So, hold on. What am I doing here? Why? Oh, here we go. Okay, so yeah, so we're kind of going to talk about, kind of what's IBS, what's SIBO, how do they overlap, what can we do to diagnose, treat, etc. So basically, when people come to my office, the most common complaint is not, I have SIBO or, there's a million different things I could say. It's I'm uncomfortable. I feel bloated. I feel like my belly's not right. I feel like my digestion, it's kind of a lot of vague symptoms. And most people come in saying, well, I've been told I have IBS, and they come in and say, I have IBS, but now I'm really feeling not great and different than usual. And the majority of people that come into my office saying that they have IBS actually end up not having IBS because there's certain hallmarks that exist there that most people who are coming in with that kind of title that they've been given don't have it. So IBS is typically a disorder of the great I'm having issues today from the heat, brain-gut interaction. So it really has to do with abnormal sensation. So it's the abnormal responses to your gut sensations. And the real, it's kind of the stretch of the wall of the intestine in any way, shape, or form is producing abnormal sensations and a threshold for discomfort that is lower than people who do not have, IBS. And it's usually something that we get to based on kind of ruling out some of the, big, bad, ugly stuff, some of the big, important stuff, and, putting the Rome criteria, which we'll cover in a second. And there's a lot of, treatment options for it. As far as gynecological cancer survivors, there is obviously quite a bit of things that are done to one's gut in the process of dealing with the cancer that could also lead to this. So whether it's tons of surgery that can, make things more sensitive, whether it's radiation that has sort of caused things. It could definitely cause some neurological disturbances, but not everything that people feel as discomfort is actually IBS. And I'm gonna kind of do this part fast so we can get to the nitty-gritty that you guys are interested in. But the hallmark of IBS is abdominal pain. It is recurrent abdominal pain. It is pain that happens pretty regularly, and it is pain that is very much related specifically to a change in bowel movement frequency or consistency. So most people coming in are just saying, I'm bloated, I'm uncomfortable. It's not really pain. And it's not often really, it's more related to eating for most people, especially when it comes to SIBO. So I think it's kind of the separation points between those two things. What we typically see is obviously changes in bowel habits, particularly being super bad in the morning in an IBS patient, actually for both IBS, constipation and diarrhea. There could be a good amount of bloating, right? So this is where it's which one is it becomes important. And there's a lot of sort of common triggers, the human triggers. There's all the foods things that we know about. There's obviously stress, etc. And it is exceedingly ridiculously rare for somebody with irritable bowel and kind of functional disorders to have any symptoms happening at night. Waking them up in the middle of the night, that's kind of considered more of an alarm symptoms, in GI, and we don't just say, oh yeah, it's nothing to worry about. So, but what if, it's like, okay, my doctor told me I have IBS, but I tried fiber, tried laxatives, tried all the over-the-counter things, I tried all the stuff, and I'm just really not really getting better. And maybe there's some other stuff going on, in my symptoms. So this is kind of where do we go from here? It's kind of scratching the surface and going beyond. So there is tons of things that can absolutely present as, IBS with bloating, with discomfort, with diarrhea, with constipation that are not or are things that are additional. So this is obviously you guys see SIBO, right here, at the top as one of the big things. But there's also a couple of other things that I think are important also specifically in gynecological cancer. This would be bile acid diarrhea, pelvic floor dysfunction. We're going to skip over the CSID and systemic nickel stuff. I think these are a little bit of their own thing that we'll probably gloss over a little too much for one set of information. But, I think these three can be quite pertinent, especially depending on the underlying issue. So now the topic at hand, the big thing to talk about is SIBO, right? So, as Jillian said, so SIBO is not, contrary to popular belief, is not an infection, right? It is not evil, foreign, bad bacteria. It is your normal flora. It is the normal flora that is part of your body. And we are covered and inhabited by trillions of bacteria. That is normal. The main hubs for bacteria in our bodies are the mouth, filthy mouth, regardless of whether you use foul language or not. It happens to be a thing. There's, millions of them in there. Actually, human bites are much more contaminated than dog bites. That's how bad we are. The skin is a huge hub. And then obviously, gynecologically and mainly the colon. So these are the big hubs for where bacteria are supposed to be. The rest of us is supposed to be pretty gosh darn sterile. There's not supposed to be very much in between. And there's a lot of mechanisms which we'll cover that are in the way to keep that from happening, to keep things sterilized, and to keep our small bowel in particular focused on absorption of nutrients as opposed to, feeding invaders. So what we say is that, it's not like, oh, I just have SIBO. There's a reason for it, the immigrant in me did not know what canary in the coal mine meant for a very long time. And I just learned that relatively embarrassingly recently. But basically means something is causing this to happen. So the big thing is that not only do we treat the SIBO, and we'll get to that point shortly, but we have to figure out why someone got it and how to prevent it from happening again, if that is possible, because recurrence is definitely high. So just so we know, in terms of risk factors, what we'll get to, but right now, no matter what the internet may say, no matter what the influencers say, the only evidence-based approach that we have at this time in medicine for treating SIBO are antibiotics. And there's various versions of things we use. It is not just Ifaxin, which is, kind of what's touted very much. It has to be tailored for the patient based on the type of SIBO they have, based on their medication allergies, based on their prior medication exposures. And sometimes, it doesn't always, things like don't always work, and we do have to do it more than once. But sort of big things focused on prevention. So particularly so, kind of covering why would someone have it? So the most common reason for someone to have it is, an infectious etiology. Somebody has stomach bug, and there's been a whole lot of norovirus going around. There's been obviously tons of COVID, and COVID very much affects the gut. But anything I tell people, if something burns your small bowel, think of it as a burn, as a wound in a way. And, things could get wonky in there because the integrity of that small bowel is no longer quite perfect. Big things, is structural and anatomical things, right? Because we have a certain, flow to the gut, right? So, kind of protective mechanisms that we have are the mouth has saliva that has some immune protection, right? And then as we're swallowing all this bacteria that we swallow on a daily basis in large quantities, everything that hits your stomach essentially will die because, the pH is 1. You have a big, big old amount of acid in there, and it sort of sterilizes and keeps things separate from the rest of your bowel until it is mushed and sterilized and ready to go further. Once it gets into the small intestine, the flow and the movement of the small intestine is super helpful, because stasis is what breeds bacteria. My patients around this know that I always say, there's a difference between lakes and rivers. Lakes are kind of full of bacteria. They're gross. They have stagnant water and, things get yucky in there. And rivers have pretty good flow, and that flow prevents that stagnation and bacterial growth from happening. So if the intestines are not moving, there's your risk factor. The pancreas dumps a ton of fluid, which are digestive enzymes, into the small bowel when the food comes in, which also have bactericidal properties. And then, before hitting the colon, there's like a closed doorway that exists that keeps the two areas very separate and prevents the backflow into the small bowel. So think about all of these risk factors as being it's disruptors. Disruptions to all of these things are the things that make it happen. So structural and anatomical. So there's a lot to do with surgery, which obviously a lot of cervical gynecological cancers have. And they're often complex surgeries that require resection of intestines, rerouting of intestines, or just actually tons of scar tissue around the intestines that happen from the treatment, from the surgery, from, obviously from chemotherapy, from radiation. All of those things will cause problems with the anatomy and the physiology of the bowel, which is a big risk factor. Low stomach acid. So kind of moving on to the next one. There are autoimmune conditions that cause this, which we always check for in a SIBO patient. But one of the big things is, PPI medication. So, everybody's on Prilosec, Protonix, any of those meds, and very often with good reason and good cause. And also patients who've been through, cancer are often on acid suppressants because they don't feel great to begin with. They're on so many meds, they're nauseated, they're getting all sorts of, treatments, and that helps their stomach, but ultimately may lead to the formation of this. So, once we find it, we try to diminish it. There's kind of the whole having H. pylori is a little bit of it's controversial at the moment because I think it's a matter of diminishing the stomach acid as well. We talked about the motility side, and that could be related to, once again, multiple reasons, but big time being prior surgery, strictures and narrowing, and as well as, once again, kind of going back to our, the patients that we have on today, anybody using pain medications, and other meds, potentially during their chemo time that are anticholinergic, like the Imodiums and all of these things that slow their gut down when they're in the process of suffering through a condition, can then lead to this happening in time. As well as, inflammatory conditions. So, once again, going back to chemoradiation that sort of wipe out the entire small bowel, kind of everything, that whole shag carpet of your small bowel gets totally basically pruned and burned off until it could regenerate. And with it can come all of these things. Pancreatic insufficiency, which would be a fairly rare scenario unless there's other risk factors in our population here. And then there's, a few other things which are less, the controllable for some. So, patients who have significant kidney disease, particularly on dialysis, people who are diabetics, chronic diabetics, just because of the sugar metabolism. Actually, elderly age in itself is considered to be a risk factor, as is morbid obesity, and also very much people who are using excessive alcohol, which I don't think is, the patients who are here taking care of some important medical issues. So this is where, kind of how we tell them apart is, okay, yeah, both of these conditions can have a lot of things in common, right? They can have very altered bowel habits, both constipation and diarrhea wise. There could be very much intolerances to FODMAPs and other things in both conditions, because that's kind of pretty common. And they both could cause a ton of gas and bloating, but there's big difference as to when these things happen. So the big thing with SIBO is people are typically doing fine if they're not really eating, and which obviously is not a solution for life, but it's more rapid responses to certain foods. So it's, oh, if I don't eat, I'm fine. If I eat, I'm going to have a problem within. So earliest would be 20 minutes, roughly 20 minutes to an hour, because that's when all of these sugars that the bacteria are able to metabolize hit the small intestine, right? So if it's like, oh, I ate, oh my God, immediately within 2 minutes, I have a problem. That's not SIBO because that food is still in your stomach. So it cannot be that scenario. So you have to think about, okay, when is it kicking up for me? And this is where sometimes patients don't realize this and they are blaming it on what they just ate when it's something that they had, maybe an hour or so before that. And they're blaming it what just went in their mouth. Whereas, kind of the litmus test, that our dietitians use is kind of the salad popcorn stuff. There are certain things, obviously, a low FODMAP salad in a SIBO patient will be fine. It will not cause any problems, but in an IBS patient, it would be a bit of a disaster. And this is the difference in timing where IBS
Okay.
patients tend to be their absolute worst in the morning. That's kind of the worst part of the day. They wake up, they're miserable. SIBO patients are their absolute best in their morning, and they tend to be their worst at night or towards the evening as they keep eating, as this keeps kind of building up. And unlike irritable bowel type stuff, SIBO can have, kind of things like, oh, B12 deficiency, big time issue that would not be part of regular IBS unless you're, obviously a vegan vegetarian patient. Weight loss can actually happen in SIBO because of malabsorption of certain nutrients. So, some of the myths on SIBO is use of probiotics. So, I'm just going to cover some of the myths before I open up for SIBO related questions before we cover some other topics. But so probiotics are actually terrible for SIBO. There's actually no data for probiotics to really do much of anything for anyone. It's a very, very murky data set. There's only 3 medically proven indications for their use, which is the potential, the only one that would matter in the patients I'm talking to right now is prevention of diarrhea in C. diff. There's some data for Fluorostor, so people who've had hospital exposure, antibiotic exposure, complications of that possibility. Other than that, it's neonates, who are born premature, and people who have no colon, who've had inflammatory bowel disease. So it's a multi-billion-dollar industry with absolutely zero oversight. They're not all created equal. And thinking about the pathophysiology of SIBO, right? If your body is hospitable to bacteria, small bowel is now hospitable to bacteria because there's something about your body that has allowed that to happen, right? So one of those things, kind of here went awry, and now your body's more hospitable. So think about the mechanism. If you're dumping a few billion more of them in that are additionally foreign, you're just kind of asking for more of them to grow. You're just inviting them. So that's, that one everybody asks, oh, should I be taking probiotics? Absolutely not. As a matter of fact, you should never be taking them again if there's something about your body that allows this to happen. There's always questions about the low FODMAP diet. And the low FODMAP diet absolutely in no way, shape, or form treats anybody's SIBO. It is a very restrictive diet, as I'm sure some of you know who've kind of been down this path. It is not an intuitive diet. It is extremely difficult to follow. People are literally referencing different things, in their food sheets to figure out, oh, can I have this? Can I not have this? It breeds food anxiety. It makes people nutritionally inadequate many times because people will cut out a lot of things that they were eating that, basically cut out everything that has FODMAPs in it, but you're not necessarily replacing them with staples of equivalent nutritional value. So it ends up being this very limited, repetitive, miserable diet. And I've seen many people, basically develop eating disorders as a result of this because they are now so afraid of food. And also moreover, very clear medical data that the low FODMAP diet should never, ever, ever be implemented without the help of a dietitian, a skilled dietitian who understands it, because that's the only way to avoid nutritional inadequacies and kind of this whole, backwards process. And it should only be there sort of, we use it as a litmus test. We use it as a temporizing measure until somebody can be treated. And then we work on rapidly reintroducing all of those foods, right? And, the FODMAPs, as you know, include fructose, lactose, a couple of different, things. And if you're lactose intolerant, me treating the SIBO is not going to fix that part. You're still going to have some issues with dairy of a different kind. If you're fructose intolerant, which is, 35% of all Caucasians have fructose intolerance, the SIBO treatment won't fix that either, but you should be able to bring back a lot of the foods that you had potentially eliminated in the beginning, because your body should be able to tolerate them if your SIBO is indeed treated. Um, and yeah, so basically, there's a suspicion, you guys are in a place where, okay, having a lot of bloating, I'm reacting to some of these things. It's fairly reliable. You know what? I'm noticing that, every time I've had an antibiotic, for a sinus infection or for a UTI, my belly actually felt better, which is weird. I expected my belly to feel worse. This is something to, obviously discuss with your gastroenterologist. The way to test for SIBO is a breath test. It is a 3-hour breath test. There's a lot of lesser quality mail away options that are not great and not as reliable. It should be a 3-hour test, which uses a substrate of either lactulose or glucose, depending on somebody's sort of risk factors and indications. We sometimes use one versus the other based on the patient. There's certain reasons that we pick one or the other. If you are diagnosed, the treatment is a 2-week course of antibiotics, after which there should be a significant symptom improvement. And if there isn't, the presumption is that either A, these antibiotics did not work, and we might need to go a different route with them, or it's gone, but that was not necessarily the reason for the symptoms that you're experiencing. And we have to dig deeper and look for other things because, this whole, IBS bubble has many, there's a lot of cousins there that overlap and cause similar things. And you are unfortunately entitled to have more than one at a time.